this special webinar. This is a very special webinar hosted by the Zambia Ophthalmological Society. We have two presenters today. We have all the way from LV Prasad, India, Dr. Muralidhar Ramappa, and also Zara Rashid from Kenya, Nairobi. So our topic of discussion today is keratoconus. We want to know what keratoconus is because in this fora, we have registrars in ophthalmology, we have practicing ophthalmologists, as well as specialists in different areas, and we all want to know what is the latest about keratoconus. So today's webinar will be 1 hour, 30 minutes. The first presenter, Ramappa, is a consultant, pediatric cornea and anterior segment specialist from LV Prasad Eye Institute in Hyderabad, India. So Dr. Muralidhar hails from Bangalore, where he completed his master's in ophthalmology in 2005 at the Regional Institute of Minto Ophthalmic Hospital. He did a long-term cornea and anterior segment fellowship at LV Prasad Eye Institute and subsequently joined the institute in 2007 as co-faculty. Dr. Muralidhar also completed a 1-year fellowship in pediatric ophthalmology at the Storm Eye Institute in South Carolina in the USA, and has worked under different professors, renowned professors in ophthalmology, who includes Professor Ken Michel of the Children's Hospital of Pittsburgh. He's an ardent investigator and has published over 60 research articles in peer-reviewed journals, 4 book chapters in prominent textbooks, and presented many papers and posters at international and national forums. And he's a reviewer for numerous international journals, including the high-impact journal like Ophthalmology, American Journal of Ophthalmology, the British Journal of Ophthalmology, and the European Journal of Ophthalmology. He's also an active member of the American Academy of Ophthalmology, the American Society for Cataract and Refractive Surgery, the International Society of Refractive Surgeons, and the All India Ophthalmological Society. In 2014, Dr. Ramappa was bestowed with Achievement Award from the American Academy of Ophthalmology for his noteworthy contribution to the scientific community. He was also awarded the Best Poster Presentation in 2014 at the American Academy of Ophthalmology Annual Meeting in Orlando, USA, for his work on 2 decades of our experience in shades. His foremost areas of interest include treatment of visual impairment and blindness in children, with special focus to pediatric anterior segment abnormalities and pediatric cataracts, corneal infection, and refractive surgery. Most corneal grafting in children include various forms of anterior and posterior lamellar surgeries, and he has developed several innovative surgical strategies in pediatric lamellar keratoplasty, and is involved in various research projects in the field of congenital hereditary endothelial dystrophy.
Okay.
So with this fully packed background information, it's a pleasure to welcome Dr. Muralidhar Ramappa. The second presenter will be Mrs. Zara Ali Rashid. She's an optometrist who trained in the UK with a BSc and MSc in optometry from Cardiff University, and she's currently a PhD candidate with KwaZulu-Natal, Durban in South Africa. She lives in Kenya, Nairobi, and is currently practicing at the Musaiga Eye Institute and Gertrude's Children's Hospital in Nairobi, Kenya. She specialized in pediatric optometry, low vision, and contact lenses. I don't know if Zara remembered me. I think she also taught me when I was doing my postgraduate studies in Nairobi. She used to come to teach us refraction with Dr. Njuguna. I know that was a long time ago. I doubt if you remember me, but I'm also one of your students. So
thank you for remembering me.
I hand over to our moderator for today, Dr. Willard Mumbi, to continue. Thank you.
Thank you very much.
Thank you, madam, for a kind introduction. And we are very happy and privileged to be in this particular platform. And I do my best to, help you in your endeavor to keep the, academics well on track.
Okay, thank you very much. So,
Mumbi, please go ahead.
Yes, yes. So we will have another presentation with Dr. MJR. That will be followed by by Zara the moment Dr. MJR finishes. Dr. MJR, please, you may proceed.
Yeah, thank you, Mumbi, again. So I shall be, the Mumbi asked me, to cover every aspect of keratoconus. Okay. So I will be touching upon certain basics also. Please feel stop, wherever you have any, complaints, issues, I'll be more than happy to resolve then and there. And he also told me, there are residents, fellows, in that context, I've also tried to include certain basics about, keratoconus. As we know, the ectatic conditions are a group of ill-defined. Sorry, are you able to hear?
Yes, please, we can hear you. I think people are joining, who are just joining, their mics are on. Kindly switch off the mic as you join. Dr. Mtela, please, you may proceed.
Oh, yeah. So as we know, the corneal ectatic conditions are a group of ill-defined non-inflammatory thinning disorders. It often characterized by protrusion of corneal tissue. Here, I've written due to unknown causes. I'll come to each of those causes. There are multifactorial. It is basically inherent tectonic instability of the corneal lamellae that actually lead to, they're unable to contain the normal biomechanical stress which is generated every day. And although, the perforation is extremely, the rare complication, but we often see, particularly in a very advanced keratoconus and PMCD. We can simply classify as a primary condition, which is primarily, confined to the cornea. So keratoconus, pellucid marginal degeneration. I'll be using now onwards PMCD wherever I use this acronym, and could be terians, keratoglobus, and posterior keratoconus. These are primarily problems lies within the cornea. There are secondary or iatrogenic, where post-LASIK or a post-refractive surgery, post-trauma, post-corneal ulcer, they can actually give rise to. And also keratoglobus can also be put under a secondary. The reason is it's basically associated with the connective tissue diseases. And it could be also classified as a central, where you have primarily see, keratoconus and post-LASIK ectasia. Generalized, as I said, keratoglobus, you have not only the cornea, even a sclera, and wherever you have a type 1 collagen, so everything has an abnormality. And a peripherally, primarily PMCD and terians marginal degeneration. Today, we'll try focus only on a keratoconus, that is a central part of the cornea. So the PMCD terians may be, little outside the from the today's topic is concerned. And keratoconus is, the very exhaustive topic. So to cover all aspects, 1 hour may be at times inadequate. As we know, it is a progressive non-inflammatory condition of the central cornea, where cornea assumes conical in shape along with a thinning and a protrusion. So the thinning, the stromal thinning is a hallmark of the keratoconus. It's often associated with a mild to marked impairment of the visual function. And again, it depends on the severity of the condition. So if you look at the prevalence, it has to be a prevalence. So 50 to 230 for every 100,000 population, approximately 1 for every 2,000 cases. In the recent time, so the prevalence has gone up. So as high as a 1 in 600 cases to 1 in 420 cases approximately. So this is primarily due to many aspects, the rising the allergy, atopy, and use of the screen time. Everything can actually contribute, and it is often bilateral, and you do have an asymmetrical manifestation. and nearly 50% of them have the onset at the age of 14.1 year, particularly in Indian, and it is also in the sub-Saharan countries too. And it doesn't have any gender predilection, and usually it is an isolated disorder, meaning it doesn't have any systemic association, unlike there are certain conditions, so like a Down syndrome, Ehlers, Marfan's, and there are many other, the retinal disorders tend to have an involvement right from a retinitis pigmentosa, fluffy iris syndrome, and so on. So can I request all of you to please mute your mic? Mumbi, can I proceed? Are there any?
Yes, Dr. MDR. Please, I'm requesting everyone who is joining, kindly mute the mic. Dr. Patel, could you assist us in muting the mics in case people are just joining in?
Yeah, thank you. Thank you so much.
Okay, thank you.
All right. Yeah. These are the very exhaustive list of systemic conditions wherein you can actually see a keratoconus. So if you get into the basic pathophysiology of a keratoconus, let's say it's basically a microtrauma, eye rubbing, it could be contact lens wearer. So wherein there is an injury to the epithelium, which in turn releases interleukin. This interleukin actually have a binding sites on a keratocyte, and that in turn can actually produce what is called as an apoptosis. This is a key mechanism. So it is a cascade of events right from interleukin 1 to MMPs. So it is a relentless cycle. That's how you have an apoptosis, stromal thinning, and lead to formation of the keratoconus. So the stromal thinning is a pathognomonic of a keratoconus. So in about 6% of them can have an hereditary background, and in a certain cases may have an abnormality in their tears and certain inflammatory markers. And what has been a causal association in most cases is that eye rubbing and atopy. And of course, in both Zambia and India, we have high prevalence of allergy. That itself is one of the important association for a keratoconus. And as I said, this is one of the hallmark wherein you have a stromal lysis, stromal thinning. You can also see, for the interesting to note for any residents around Fleischer's ring. So that actually defines the base of keratoconus, where because of a pulling up at tears, so where iron get oxidized to form at the basement membrane. So this can be one of the important good marker in established keratoconus. It will tell about the perimeter of the cone, which is also helps in a decision making in a surgery, and it is also actually marks what is the size of corneal transplantation. And this is again we call a Pearl's test, where you can use the Prussian's blue to identify this is an area where you can actually see a basal deposition of iron in the basal epithelium. And histopath, in addition to the disruption of the Bowman's membrane, so there can be times wherein you have a fibrous tissue interforce. It is believed that Bowman's layer is one of the toughest layer. So the Bowman's layer is also disrupted. That is one of the hallmark when you actually examine these cases under microscope. And all it necessary is just epithelial trauma, as I said, so that itself, activate the cascade of event and eventually results in a stromal thinning. Once the stromal thinning, established, so this is unable to contain the normal biomechanical stress, so that results into forward moving of cornea and results in a keratoconus. Although it is a rare phenomena seen about 2 to 5% of the cases, although we don't have actual prevalence of an eye drops. So as the progressive stromal thinning, so once it stretches beyond the elasticity of the Descemet's membrane tend to break and it start curl towards the stromal side. It has a property to curl to the stromal side. So this is particularly seen in the young children who otherwise tend to rub their eye much often. So results in a, the fluid actually seeps into the corneal stroma, and you can have a varying degree of a corneal cloudiness and eventual scarring, and a small proportionate of these cases end up inviting a lot of blood vessels into the corneal stroma. If we don't identify the eye drops in timely manner, so sometimes it can actually set a poor prognostic factor for a corneal transplantation. So as I said, today we are dealing only with the keratoconus. Is one of the most common ectatic condition, usually bilateral. Onset is at the teenage, as I said, 14 years in India and around 16 in a Western population. And one of the most common area is the inferior paracentral thinning, and protrusion is the thinnest is at the apex of the keratoconus. And as I said, Fleischer's ring is an iron deposition which demarcates the base of the cone. So it also helps in a grading of keratoconus, which I'll come to shortly from now. And in a certain cases do have a scarring. Scarring may be in a Bowman's membrane, maybe in the stroma, maybe in the Descemet's membrane, depending on the what is the consequent cause for the scarring. And striae, stromal striae are most commonly seen in these cases. So this is about various clinical signs one get to see in a keratoconus. These are the certain example how to distinguish PMCD, wherein you have a typical, so the kissing, the kissing bird sign, this we call it as typically. And this is a global pachymetry. If you look at it's around 250. So that's suggestive of a keratoglobus with a steep cornea. They can have a very large white to white diameter up to 13 or 14 millimeter. And it's basically a constellation of clinical signs. The keratoconus, now we know that there can be a external signs that is in a very late time. And you can see certain signs in a slit lamp in a moderate keratoconus. And a very early, you can actually see a refractive sign, something like even a scissoring can be one of the earliest, the sign which can be discernible in early keratoconus. And the current focus is actually has moved from, diagnosis of keratoconus very early on in a subclinical form, thereby actually minimizing the progression and also the consequent complication related to the progressive keratoconus. Since we have now prophylactic procedure that helps in halting the keratoconus. And these are the various symptoms, you get to see in a cases. Depending on the bilateral, unilateral, asymmetrical, late or early manifestation. And though you have a variety of clinical signs, right from external signs to slit lamp to, some of the, video keratography. I'll come to each one of this. And we know this is a very advanced sign, and it may not have a relevance, in the, currently, although it may be relevant about 50 or 100 years ago, may not be relevant, because, by if we recognize this, by then, the damage in the stroma is already has happened, and there are a lot of irreversible changes. These are the cases may need either contact lens or advanced lamellar surgeries. Rigidity sign, so it may not be very pathognomonic. You can actually see a cone on the nasal side if you show a torchlight from the temporal side. It's only for knowing this one, and from the academic point of view, and you may not elicit this consistently in each and every case. As I said, corneal thinning definitely would be able to pick up. Again, this may not be very early sign. One of the earliest clinical slit lamp sign is change in the specular image. So that can be actually picked up very early on. These are the oak striae, which are typically seen in the stroma. These are nothing but a stress folds, and you exert pressure using your finger on a slit lamp, and these folds actually disappear. That's how you distinguish this from the other causes of the stromal striae or deposits or some form of abnormal corneal nerves and so on. As I was talking to you, Fleischer's ring, so you can actually see in a cobalt blue under. So this actually defines the perimeter of the cone, and this is actually the base of the cone. So the entire abnormality within this particular circle. And these are the certain subepithelial reticular scar, which seen in, due to the Bowman's distraction. So the scars also represent, one of the very sure telltale definitive sign of a keratoconus. And at times, the presence of scarring also, helps in retarding the progression of keratoconus. We do not know at this point in time. It's a natural way of, protective response, but this can also be obviously seen in a subepithelial region. And prominent nerves can also be seen in a keratoconus. These are the fine network of, certain times white darts, and they have a typical dichotomous pattern. Apart from a keratoconus, there are a variety of conditions wherein you get to see a prominent visible corneal nerve in the corneal stroma. And these are the certain subtle thing, either a hurricane or a vertex keratopathy. So this is typically seen, if you can see, this is a, we call it as a vertex keratopathy. This particular boy has a peculiar way of, rubbing his eye in a very circular pattern. So the point I want to emphasize is that, at this point in time, eye rubbing seems to be one of the single most important triggering factor in a susceptible individual. I do not say every person who rub eye, they develop keratoconus. At least in a susceptible, individual, it can actually trigger the keratoconus causation. And our next speaker would be, talking more on this. So you see a typical scissor reflex. This can be a very earliest sign. It can be picked up by one of the brilliant optometrists. So again, a Charlock's, which is actually, again, oil droplet reflex, which actually defines the perimeter of the keratoconus. So it also has to be differentiated from the anterior lenticonus. Sometimes anterior lenticonus actually looks exactly like this. One of the ways is doing is that, examining under slit lamp, look at the anterior curvature of the lens. Otherwise, one can actually mistake microspherophakia or anterior lenticonus for a Charlock's sign of a keratoconus. And there are variety of classifications. So right from a chromics to, there are several grading system. So we can, based on the K value, you can, define them as a mild, moderate, advanced, and severe. And this is basically based on a keratometer and old TMS. So it may not be relevant, this chromics grading system, but in a very advanced cases, when we intend to plan surgical intervention, one can actually rely on that. Second, based on the shape of the cone, it may be nipple, oval, or a globular. And each of them actually talks about, the extent, kind, and once you recognize this, your treatment modality actually varies. So the nipple tend to be very small, less than 5 millimeter in circumference. It is typically round, and where contact lens fitting is much easier and simpler in these cases. The fluorescein actually shows that, the contact lens touch. And oval, they are a little larger, 5 millimeter, often displaced inferiorly, as this picture is actually showing. So there is an inferior displacement, unlike a nipple, which is typically central. This is a inferotemporal, most common. And globus is a much larger than 6 millimeter. I may involve the central part, or sometimes it may be, your apex may be displaced downward. And nearly 75% of the cornea is affected. And this is the most difficult to fit the contact lens. So the traditional, now since we have a huge armamentarium of contact lenses, we can try various contact lenses, even in a globus variety. So to define, to give a perspective, keratoconus could be early, form prostate, and subclinical keratoconus, wherein you can use a modern tomographic device to pick up even before you see any physical clinical signs, right? So by picking up, very early on, so we would be able to label them, monitor them closely, and try to remove all the potential, risk factors like eye rubbing, atopy that can be taken care. So in order to minimize the consequences of keratoconus. And you do have a various diagnostic, though, so almost 100 years ago, the placido disc technology was used, wherein the form fruste keratoconus, that is abortive keratoconus, wherein you have a deviation in the horizontal axis, between 1 to 4, or a typically less than 4-degree deviation. Earlier, a mild keratoconus between 4 to 8. And that's how, people used to actually, devise and categorize in those days. Then they didn't have many, surgical thing, they used to do typically epikeratopakia or a penetrating keratoplasty. And of course, contact lens were there. And photokeratoscopy, again, it has a various indices, which actually helps us directly go into the various topos. So what is important to note is here, so the abnormal bow tie pattern. So it may be asymmetrical and there is a more than 30-degree deviation, or you can have a inferior asymmetrical, superior asymmetrical. So these are all abnormalities you typically see. And this particular diagram is illustrating, not only this is asymmetrical inferior steepening, here is a more than 30-degree deviation. That is also one of the earlier signs of a keratoconus. So the Rabinowitz group has come with initially, these are the certain criteria where increase in the corneal power and inferior superior asymmetry and a skewing up the steepest radial axis more than 30-degree. These were the initial, Rabinowitz criteria for helping to make early diagnosis. And of course, one has to be, there are caveats. So there could be a contact lens warpage, or sometimes inferior eyeball compression, or a misalignment, when the topography being captured, if the patient is, not cooperative, looking downward, that can also give a kind of an inferior shifting of the affix. So that may actually give a pseudokeratoconus-like picture. So these are the certain things one has to actually rule out before labeling somebody as a keratoconus. And these are certain absolute values, inferior superior value greater than 1.4, and superior to inferior you can consider up to 2.5 diopter, okay? And the central corneal power more than 47. And the skewing, as I said, earlier we had a 30-degree. Now the modern topographers, it's defined as a more than 31-degree. That is suggestive of keratoconus. And what has been, there have been a variety of, the indices. So I'll skip the certain things, and we may not have an access to all the gadgets. And each grading has the values, something like this KSI, where keratoconus severity index. And what I like is a KISA index. It's been really very consistent, wherein you use the, it is a byproduct basically of the 4 indices. You take a K value, ISK value, inferior superior asymmetry, and SRAX more than 1.5 and more than 21-degree if you put in. So if the values between 60 to 100, keratoconus suspect, and you have an 100% KISA index, that is a frank keratoconus. And since, now we have tomographers. Tomographers have a biggest advantage where they actually also look at the posterior float. So that makes, the imaging devices are much more robust. We would be able to pick up even the earliest changes. The earliest changes, in fact, happens in the posterior stroma. So the abnormal maps wherein your posterior float difference is a more than, even as low as, 0.05 diopter, 3 millimeter irregularity more than 1.5, 5 millimeter more than 2. And peripheral to central, if there is even a 20 micron thicker and thinner, that also shows abnormality. And a lot of derivatives have come, right from, the new devices like a pentacam, Galilei, can actually helps us pick up a subclinical keratoconus very early on. And these are the typical, the posterior, you have a front float and this a posterior float, and which helps us picking, these conditions much early on. So once we establish a diagnosis, so if the time permits, I'll come to the lot of illustrations wherein, how to actually help pick up using a modern devices. If you name one particular device, I can show the images relevant to that particular instrument, and we can together actually help make a diagnosis. So once you have a diagnosis, then the management would be easier. So you have the armamentarium, right from the glasses to contact lens to some of the surgeries. So these are all governed by, so there are various factors. What is the age of the patient? What severity? What stromal thickness? Does they have any associated risk factor like an atopy, VKC? What is the current vision? What is their visual demands? Location of cone, how fast it is progressing over 6 months to 1 year. That would also helps in deciding or surgical, strategizing the surgery, and where is there a presence of scarring in the Bowman's or a Descemet's level? What is the other eye status? Hydrops, patient expectations, and also if the closest relative, one of the sibling has a keratoconus, sibling has an eye drops or any complication, that also, govern the way we actually deal these cases. And of course, the spectacle are mainly reserved for a very early keratoconus. And if they don't have any asthenopic symptoms early on, we can manage and institute all the protective measures in these cases. This is one of the typical algorithm wherein based on a K value, you can actually, tailor them, whether to go for a contact lens, when to plan for a collagen cross-linking, when to plan a surgical intervention. Although it's not an absolute, so this at least actually tells us about how we can actually give a roadmap to the patients. It's very, very important before we contemplate on a collagen cross-linking. It's very important to take care allergy. So this can actually complicate or compound the problem when you actually do the collagen cross-linking. So what we typically do in a cases wherein they merit contact lenses, we do the contact lens trial and assess their risk. And if they are willing to, if the younger patient has no stromal scarring, and if the signs, clinical signs shows the progression, they have adequate stromal thickness, we would actually expedite collagen cross-linking. Now, the systematic analysis for the last 10 to 12 years have actually shown the beneficial effect of doing a collagen cross-linking when the patient is very young. And these are the certain objectives of the contact lenses. I'll try skip contact lenses. My other speaker would be, giving a detailed description on that. And as I said, the younger patients have a higher propensity to, so the progress much higher. So that's where we actually go ahead and do a collagen cross-linking. Collagen cross-linking, actually, we are helping to a natural glycosylation. Thereby, the two adjoining collagens, when the free radicals are released, so they combined. It's kind of a hydroxylation reaction. Thereby, collagen fiber eventually get, strengthened, thickened. That's how ultimately the effect actually lasts. So the riboflavin is a photosensitizer. So when it gets excited by the UV ray, UVA particularly, that particular wavelength actually releases a lot of reactive oxygen species, which in turn helps in a collagen cross-linking. So it's not virginally belongs to ophthalmology. This particular technology we have taken from, again, dental sciences, where they use a polymerization as well as a collagen cross-linking for the dental fillings. So these are the certain indications. If you have, in a between the two visits, if there is a more than one diopter increase in the K maximum, and the difference between K maximum and minimum, and mean if it is more than 0.75, pachymetry if it is decreasing more than 2% compared to the previous visit, and corneal apex power is more than 1 diopter increase, or a mean spectacle corrected refractive error more than 0.5. So even a child is having an unstable, generally progressive, since the collagen cross-linking is a relatively very safe procedure, there is no harm in actually going and expediting the intervention. Dr. Mumbi, kindly let me know when to stop, um, and accordingly, I'll stop. And this has been.
You still have plenty of time, doctor.
Okay.
Yes, thank
So
you.
let me please indicate when
Okay.
I have to, yeah.
Yes,
And
yes.
the reason is I don't want to have a lengthy monologue. I have a lot of slides, including images, pictures. If there is a discussion initiated, I will take to that particular the case model, and we'll have a the discussion, then a complete monologue. Okay.
Yes, doctor. So we are collecting some questions just to everyone. You can post your questions if you have them here, or you can keep them at the end of the presentation. So you still have up to about 17 minutes thereabout for the presentation.
So, but the collagen cross-linking which I have done is a 5-year-old child. Okay. So this particular child not only has a family history, and he showed a big progression, and so he didn't have any scarring, he didn't have, and has adequate stromal thickness, and he was very, very cooperative. In fact, this child was referred from Seattle in US, and I did at the age of 5. He surprised me. He cooperated so well, we could go ahead and do an accelerated collagen cross-linking. I think it is 8 years now. He's been managing very, very stable with the glasses. Very surprised to see he still has a mild keratoconus. So that is an importance of doing early on tomography, which helps you pick you up the subclinical keratoconus. Thereby, you can actually minimize the all consequent complications. And any child who has a severe VKC, and if they have a non-compliant or inability to come for a long-term follow-up, so these are all the cases where keratoconus actually very, very beneficial. And the various protocols. This is a virginal protocol wherein it is a very lengthy procedure, and currently what we do is accelerated, where 10 into 9, that means for a 10 minutes we use a 9 volt instead of a virginal technique. They used to use a 3 microvolt for a 30 minutes exposure. So the 9 minutes, the accelerated protocol, it's been compared head to head with the traditional, and many studies have actually shown that accelerated protocol is equally effective. And the various studies which actually shows, although when this about 2009, before 2010, there were only 3 were the randomized trials, meaning otherwwise they did not treat intently, and they show the significant worsening of the untreated eye. So now we have ample literature to show the beneficial effect of an early collagen cross-linking. So the earlier age and location, if it is a central and very early or even advanced disease, they are also get beneficial. And it also been proven to be very good even in a thin cornea, although people earlier used to believe in a thicker cornea. So you need to have enough stromal bed once we collagen cross-link them to support or give a tensile strength. Even a thin cornea actually works equally well. And as again a K value, it should be less than typically 60. 60 and above, they may not have a marked improvement. And in all these cases, the epithelium off is the way. So epithelium on have shown, extremely variable results. So So it's very, very important to remove the central epithelium over the cone. Then, either you can go with the conventional 30 minutes, or you can go the accelerated 9 minutes. I mean, the 9 millivolt, 10 minutes actually works equally well. And based on the corneal pachymetry, you have different formulations. You have a normotonic, isotonic, hypertonic, and each of them have a different concentrations. There are also nanoparticles in the form of riboprotein. So each of them, based on a manufacturer instructions, we may have to see based on the strength, how many times you may have to instill, what are the additional precautions one has to take. And hypotonic, typically we do use in corneas which are less than 400 microns, including the epithelial thickness. As I said, so there have been a head-to-head comparison between accelerated and conventional. Accelerated, particularly, it saves you time if the child is an uncooperative, and it also helps you treat, more number of cases in a given case, and it also reduces the cost. And the certain other advantages, it also prevents the the corneal desiccation, because the cornea may get dehydrated when you actually sit in an operation theater for nearly 30 minutes. And there are many investigators actually looked at a transepithelial. So my personal opinion, in a transepithelial may not be that effective. At this point in time, it's very, very important to remove the epithelium. And also currently what dosing we are using, in a conventional technique, we use a 3 millivolt. In accelerated, we use a 9 millivolt in a 1/3 of the time. Okay, instead of 30 minutes, we just complete the irradiation in a 10 minutes. So that gives the enough threshold, and this is proven to be least endothelial toxic. So that's how the dosing and duration have been calculated. I'll skip this particular slide again. It's a depth, and these are the certain modifications which we talked about, hypoosmotic. And there are certain newer machines where it can actually customize pachymetry, and also the debridement, and can be combined with the collagen cross-linking. Although these are all experimental, what has been traditionally followed is a traditional conventional Western technique or accelerated protocols. And people have used these are the various formulations, different investigator, hypoosmolar, and they're equally effective. And particularly when you have a cornea which is less than 350 microns. So meaning, you are swelling the cornea prior to application of the UV rays, thereby you can actually, provide some immunity to the corneal endothelium. And although there are certain concern, so it may alter the biomechanics of the swollen cornea, so it may not be as effective. So there are many confounding factor here, not only, the stromal swelling and stromal loosen up, which happens, and also the amount of stroma left behind may be much lesser to provide the adequate tectonic stability. So in a thinnest cornea at LV Prasad Institute, we do not treat less than 350 microns. So certain times, your pachymetry, which you measure from various machines, may not be very accurate. So what I would recommend, ultrasonic pachymetry would be a gold standard, or even one of the device like a Pentacam, Galilei, if it is consistently standardized, it can give you very high precision pachymetry, because these machines have been designed in such a way, when you have a thinnest cornea, they tend to underestimate, thickest cornea, they tend to overestimate. Sometimes it may range between 10 to 30 microns. So that may actually alter your decision. Therefore, what we reliably do is ultrasonic pachymetry. And what are the complications? So although, as I said, the collagen cross-linking is a very easy, simple, and it is an extraocular procedure. So, there are only few noted complications. So one has to ensure that, their allergies under good control. They do not have a lid adnexal abnormality, which may contribute, should not have any dry eye. So these are the certain predisposing factors. So may results in a either sterile or infective keratitis. Sometimes may have a persistent epithelial defect leading to corneal melt. And nearly about 10 to 16% of them, they may have a corneal haze or opacification. Certain conditions, if they have a TGF beta group of abnormality, so their keratocyte tend to overreact abnormally, they tend to have a scarring. So those cases have to be recognized. And corneal edema because of endothelial insult. So this is particularly happens if we, either, do the longer exposure, or if we choose a cornea which is much thinner. These are the certain, the complications. And of course, the treatment failure is also one of the aspect.
Dr. Mdiara, you have 13 minutes to go.
Okay.
Yes.
Perfect.
Yes. So yes. Again, I'm just reminding everyone, if you have any questions, you can either keep them at the end or you can post them in the chat box. Thank you.
So there are various investigators have tried to, look at, the actual beneficial effect of intracorneal rings. So these are not only tedious, very expensive. You would need something like a femto suit to perform, and most cases they may not be comfortable, in any form of a rings. The patient tend to have a pain, discomfort. I myself have removed many rings from the cornea. Although I'm not a great believer of, the intracorneal segments. I've never, learned or try to, implant these rings. It may be effective in a mild to moderate cases, and it may help them to again go back to contact lens, and it has its own drawbacks. And the surgical intervention, we typically, go for a very advanced cases where they are not even suitable for a contact lenses, or a contact lens misfit, or sometimes they have a significant apical scarring or a scarring in the visual axis. These are the certain cases we actually take for a surgical intervention. And both DALK and PK give an extremely good outcome. Keratoconus, in fact, is one of the condition wherein, they do have extremely good results. So the 10 years graft survival is close to 95%. So that's actually a very great thing. Although, a surgical intervention, we keep it as a last resort. This is one of the recent study wanted to quote that in a pediatric cases, particularly under 14 years, if it is considered. So what they've actually showed is there is a 24% regression rate. So the contemplated over is 15 years or younger. So when you do actually collagen cross-linking much earlier, it seems to be very, very beneficial, particularly early pediatric keratoconus. If you see a progression in a child, do not wait. And one has to control the allergy, as I said. And if we don't, the higher risk of, failure, meaning, the progression is much higher. Sometimes when you do a early collagen cross-linking, because the turnover for the stromal replacement is about 3 to 5 years. So the collagen which you have cross-linked must have been replaced by the host tissue. So we may have to repeat. And personally, I haven't repeated. By my colleagues, some of them have repeated if there is a persistent progression, because of it could be treatment failure, it could be very aggressive disease. And we do not recommend the re-intervention within the first year. Typically, you need to give at least a 1 year time before going for a second intervention. And there are certain cases wherein, so the tricky thing is even during the pregnancy, the keratoconus can, under the influence of variety of hormones, it can actually progress. And what if keratoconus, where you have an endothelial dystrophy, the endothelial are subnormal. So here we may miss, though there may be a false negative results here. We may not be able to pick up. And these cases wherein, at this point in time, we do not know whether we can offer safely collagen cross-linking. And again, this slide has been repeated. So as I said, again, a progression or a treatment failure at times. So maybe due to several variables, right from if we do not peel up epithelium, if we do not, calibrate our instrument and do a proper exposure, and the power setting is the most important, whether you are choosing 3 millivolt, depending on the duration, or a 9 millivolt. Okay. And if we take care a lid adnexal dry eye allergy, so normally, these younger children's, their epithelium heals within 3 to 4 days without any major issues. And so the progression, has been reported to be as low as sometimes 0 to 16.5%. So following the collagen cross-linking, and can be seen within first 2 years. And generally, typically, the wear off effect, it's beyond 5 years. Once the collagen cross-linking, that's a typical, collagen replacement time. And the risk factor for the failure or a progression, even after collagen cross-linking, are very early children and who are intense or habitual eye rubbers. If they have a pre-existing or a coexisting VKC or atopy, and to begin with, they had extremely steep cornea, close to 60 diopter. They had a thin cornea. So the cornea which we end up, collagen cross-linking may not be adequate to provide a tensile strength. So that can also lead to the failure. And a post-LASIK ectasia. Even these cases, we do not completely understand their biomechanical strengths at this point in time. Case is typically seen between 1 to 3 months. With the steroids, they tend to regress in most cases. And advanced keratoconus may be one of the risk factor. So certain times, up to 1 year, they tend to actually reduce eventually. There is a scar remodeling which takes place. So believe me, after collagen cross-linking, cornea will likely to have in most cases some amount of haze. So that is a normal, that's maybe a healing response. And the certain cases, they may have, the secondary complications. Sometimes if we do not recognize herpes, so herpes can get actually, aggravated with the treatment. It may get triggered. And if we ensure minimum of, the 400 microns is a thickness, so we would be able to, eliminate this particular complication, endothelial insult. Keratitis, as I said, variety of causes. So it's very, very important to, remove that contact lens within a week's time and see if there are any sterile epithelial defect and look for, possible cause. See, there are some certain cases, you have a Down syndrome, there is a cognitive impairment, child, doesn't cooperate, they tend to rub eyes, they don't, keep the, bandage contact lens until the time, epithelium safely heals. In such a scenario, what we do is we put a tarsorrhaphy. So that will serve as a very protective thing. So you can temporarily, suture tarsorrhaphy, which could be conveniently removed at the end of 1 week. So that will actually ensure, so they have the epithelium heal within a week's time. Since, you put a stitch tarsorrhaphy, it is extremely painful. These children may not touch or rub their eye. And we also have the toric ICL. This is considered in a very stable keratoconus in a mild cases and beyond 30-35 years. And they have a very minimal reports about the stability and a long-term safety. So I've never practiced a toric ICL. And you have heard, the people have been, this has generated a lot of heat in the recent past, the Bowman's-Lear transplantation. So at this point in time, we don't have enough, the evidence, to show that, Bowman's-Lear consistently work in these cases. Although there are few groups have actually shown, in the interest of the time, I am not going in detail. And whatever, what we believe is the incision they make, the pocket they make in the cornea, perhaps, it is neutralized by, doing incision and suturing up that pocket rather than an actual, the significant reduction or a stabilization of the key. At this point in time, there are no favorable factor. And we were talking about eye drops, although it is a very rare, late, unacceptable complications. It is mainly actually seen where you have an extreme corneal thinning. Okay, so this is one of the precursor for a development. So the rupture in the DM and fluid pocket accumulates and leading to consequent changes like a scar formation. Certain times, they attract a lot of the vessels, the engage and extremely thin epithelium and extremely thin stroma. And if they have a thinning at the cone, okay, and already, the Bowman's membrane actually shows a disruption and absence of stromal. Actually, the presence of a stromal scarring actually offers certain degree of, resilience to cornea. It may make the cornea a little more immune against the development of the eye drops. So these are the risk factors. We need to be extremely careful. If the child has a one eye drops, I do not hesitate. Even if the other eye has a mild or a subclinical keratoconus, I would go ahead and do the collagen cross-linking. Thereby, it helps minimizing the eye drops. Eye drops can be very catastrophic complication, particularly in children with the keratoconus. So we did do the lot of investigations, what is the right strategy to manage. So the Descemet's membrane, it has its property to curl, so curl inward or even a curl outward depending on the size. And look at this actually potential gap, actually determines. So we undertook this particular study almost 12 years. Then Sayan Basu was my student, and this was one of the paper where actually changed the the way we actually manage. So what I recommend, I'll quickly skip all the things. I'll give an important thing. So if you note, there is a large cleft,
Dr.
and you can use one of.
Dr. Mdiara, you have about 2 or 3 minutes to wind up.
Okay, yeah, sure. So one of the expansion gas actually helps in uncurling the Descemet's membrane, thereby facilitating early healing. But if you look at in a long, there is no difference in the final outcome. It is only it can be offered only to the people who want a very faster recovery. It may not influence the long-term visual prognosis. Once the eye drop heals, as a rule, the cornea gets flattened, so you can again go back to the contact lens. My personal opinion, as I said, for a faster resolution, and if you have a large area of the cleft, and if the edema is involving the entire cornea, I'll just give an algorithm here. So how we actually go ahead. I'll just take a couple of minutes. So one of the important thing, one has to treat the allergy. So if it is a non-progressive, younger than 15 years, you can go ahead and do a collagen cross-linking. Old, look for other risk factor before going for a collagen cross-linking. The vision is satisfactory. You can either switch to contact lens or even a glasses, depending on their preference. And only in a very unsatisfactory, if their vision or a tolerance to contact lens is a poor, then we actually think about surgical modalities. In a progressive, wherein if you have an adequate corneal pachymetry, so I would recommend collagen cross-linking. And most important, their lifestyle modification has a long role, particularly in preventing the complications. And again, eye drops, small, large. So if it is a small, very innocuous, we don't need to do. If a large, involving large cornea, then we would go ahead and do the ear tamponade. So it may be one of the expansion glass, SFX6 or C3F8, whatever you have an access. And PK is only last resort. And DOLC we can offer in a cases wherein, they never had an eye drops or they have a very small, wherein you may have to do a stromal dissection. Of course, with the compromise, the visual axis may be scarred. So this is a nutshell about the keratoconus. This is one of the broadest algorithm. So this helps in, maybe planning a generalized treatment plan, but the decision which you take has to be tailored to the patients. As I initially said, right from the age, gender, other eye condition, and how fast it is progressing, scarring. There are many factors which helps you, choosing one of the treatment modality. So I'll end here, Mombi, and if there are any questions, I'll be more than happy to take them to the individual sections.
Okay, so
thank you so much.
Yes, Dr. Mjera, thank you very much for taking time off. I know that side it must be, is it 2030 or 2130? This must be 2130 in India. So this is quite late, that side. We appreciate for taking off time and helping us discuss this topic. Before we go into questions, I'd like to recognize the presence of Dr. Mwale, Dr. Mutati, Dr. Njuguna, and I've seen Dr. Mukiri joining and Dr. Owenga, and everyone who has just joined that I'm unable to recognize. Thank you very much for coming. Please, if there's anyone who has a question, please come in and you can ask. We have a few times. Yes, so there was a... Is that a question? Is someone asking a question? Oh. Yes, please, if you don't have any, if you're not talking, kindly switch off the mic. Yes, there was a question that was being asked about the age, the youngest. I'm getting feedback. I'm not sure from where. Okay, so initially there was a question that was asked about a 5-year-old.
I think the feedback is from Charles Maswai. Kindly mute your mic, please. Dr. Mumbi, you are on mute.
Yes.
Thank you. Yes, thank you. So there was a question that was asked in the chat. Fortunately, you answered the question already. It was about the youngest that you have ever done. I think you mentioned 5 years old. So in in these patients, do you do it under GA?
No, he cooperated. He was very cooperative, topical. Yes. And I have done a GA in a cases where you have a Down syndrome. Those children, were difficult. I've done a bilateral since, we've taken under EUA. So, I mean, LMA, so laryngeal mask. So we could do under general anesthesia. Okay. So, and wherever possible, if they have a cognitive impairment, I would go ahead and do bilateral, put a tarsorrhapy and, eye shield, and parents have to be really vigilant 24/7 for the, until epithelializes. Once epithelium heals, and you will not have any complications. So the epithelium healing is one of the key important.
Yes, I can understand that the pain the kids would go through. Do you normally give them also oral analgesics?
Yes, you're right. That's important thing. So actually, contact lens, makes things much more simpler, easier pain management. So if you put the contact lens immediately after the intervention, so it will serve as a splint. The pain, everything get ameliorated. Okay. So if you do not put a contact lens, the child have a lot of symptoms, lid swelling, and they don't even let eye drops being put inside. And the systemic analgesic, yes, is very, very important in these children. It's a very great point.
Anyone with any questions before we proceed to the next session?
I mean, that was a great talk, Dr. MDR. But just
thank you, Dr. David.
Yeah. So for most cases in Zambia, we are doing corneal cross-linking and PK. On your algorithm, I noticed that you had mentioned that PK can be done in cases where you have a large hydrops, and DAOC applies in cases where you have smaller size of hydrops. Would the same apply where, for example, DAOC would be the most preferred procedure rather than PK for all the cases?
Absolutely, absolutely. But if you look at, the PK results are much better. The reason is, you have a very pristine cornea. You don't have a residual bed. If you can achieve a big bubble while doing, the DALK procedure, okay, that actually gives the results which is comparable to the PK. If you end up leaving behind, significant amount, let's say 50 to 100 microns of stroma, which is not completely pristine or transparent, so that produces an interface haze, so they may not achieve the results of a PK. But one of the the trade-off is that you would eliminate the lifetime risk of allograft rejection and consequent graft failure. So that's the biggest advantage of a DALK. And also DALK advantage in a children is that you retain the toughest DUAS Descemet's endothelial complex, and these injury, these children are very not only prone for injuries and eye rubbing after transplantation. So that makes them much more immune to the complications. So the natural choice would be, you are right. So the DALK is the natural choice in these cases. And only exceptions you go, you have a large previous eye drops, or you have a significant, the stromal scarring, you are unable to bear the Descemet's membrane. These are the certain indications where we prefer a full thickness keratoplasty. But if you look at the long-term results, keratoconus is one of the indications where graft survival is extremely good. So the more than 95% graft survival in a keratoconic eyes. Of course, provided the patient has to complain, has to put in medications.
Hey, thank you very much.
Thank you, David.
Yes, I know, Dr. MDR, you mentioned rightly at the beginning that allergies are a greater risk, and most of these kids will be having eye rubbing. I used to notice that long term, you'd keep these patients on tacrolimus. I know in our population, and most people are listening, where we normally give steroids. Would you just comment on the long-term treatment for allergies?
Oh, I agree with you. The tacrolimus seems to be very, very safe, and you have a new data, randomized data, which showed even up to 3 years, topical tacrolimus can be safely used without any complications. So one of the contraindication, if a child has an herpetic blepharitis, blepharokeratoconjunctivitis, if the child has something like a xeroderma pigmentosa, or any child who has an immunosuppression, or any child who has a risk of developing a ocular malignancy, these are the certain contraindication for a tacrolimus. Otherwise, we are using about 1500 times dilute form of a tacrolimus, and ointment really works very well, recalcitrant cases. All we have to use that 0.03% tacrolimus. It can be applied to the lid margin, the way they apply eyelid cosmetic. It doesn't have to be put into the cul-de-sac. It works remarkably well. And I agree with you, you can't use a steroid for about 8 to 10 years time and end up having a cataract or a steroid-induced glaucoma. So this is a lifesaver. Tacrolimus has actually changed the way we manage, allergies, particularly in India.
Are there any questions so far? I think there's none. Thank you very much, Dr. MDR.
It's always a pleasure, Mumbai.
Yes, we appreciate. We hope to go upon you again next time whenever we are stuck.
Absolutely, absolutely.
Okay. Would like to invite Zara. Zara, you have about 30 minutes or so, and then thereafter we have a session of questions. Even as she is presenting, we can still ask questions in the chat box there. I'll read them. Yes, Zara, over to you.
Thank you. Thank you, everybody, for the opportunity. And I can see we have quite a varied audience today. We have some optometrists, we have some ophthalmologists as well. So thank you all for joining us today, and thank you to the Ophthalmological Society of Zambia for inviting me. I'm very honored to be speaking alongside Dr. MDR from LB Prasad. We've learned a lot, and thank you for the earlier session as well. So I will make sure that we don't have an overlap, and I'll talk more about the management and some case studies in Africa that we've done as well. So in terms of, we all know that it's progressive, we know the irregular cornea, etc. And those were all covered earlier. I think what is really important for us to be able to, many of the optometrists see these patients very early on in their practices. And especially now with cross-linking, we want to really recommend for these patients to be identified as early as possible. Many patients come to us in, by the time it's already very advanced. And then we have to tell them, possibly cross-linking may not be possible because the corneas are too thin. And they'll ask you the question. They said, but I was going to my optician every year and I was religious about it. And I was telling them that I wasn't quite seeing well and my prescription was changing. And the classic sign is when patients tell you that they either see double or they almost see this ghosting. And that will start very, very early on. And they will even tell you that there's a slight difference between the two eyes. So it's really, really important to understand what does this mean. When they look at the letter A or the letter E on the chart, the 660, they'll always tell you that there's another one. There's a little bit of shadowing, there's a little bit of ghosting, and that should already trigger a lot of people in primary eye care to say, could this be keratoconus? Could something be happening at the level of the cornea? And to start investigating a little bit more. Retinoscopy, I cannot emphasize. It's great to have all this equipment where you have corneal topographies and corneal tomographers, but we don't always have the opportunity to have this, especially in rural settings, in settings where we have low resources. We don't have that kind of equipment. It is still our duty as eye care practitioners to be able to pick up. Even optometrists, I remember whenever I'm talking to optometrists, they will tell me, they'll say, but Zara, we don't have a topographer. We can't diagnose keratoconus. And I said, that's not true. You have a really cheap instrument in your hand that you should be using, that we should not forget. What happens to many of us when we are practicing, when we leave university, we forget the retinoscope. We become so reliant on the autorefractor, and that doesn't really tell us. So, somebody comes into your optical shop, you use the autorefractor, you prescribe them glasses, and they leave your place. And many times you will go, this condition, keratoconus, will go undiagnosed. So my appeal to everybody who is in primary eye care, please pick up your retinoscope, and especially on children who do have allergic conjunctivitis, because that's our group that we will be able to pick up keratoconus very early. I'll show you how you can do that later on. Of course, we talked about keratometry. Make sure you do your slit lamp examination, the oil droplet reflex, etc., and of course, thinning cornea. I really like this image that I'd found a number of years ago, and and again, just emphasizing the importance of retinoscopy. Really, really simple tool, and all you need to do is just sweep the eye, and you'll be able to see the split reflex or the scissor reflex. I'm just going to play this video so you know. I mean, sometimes it's so easy for us to say split reflex or scissor reflex, but until you don't see it yourself, you don't really know what you're looking for. Okay, so this is the normal protrusion you all see, and by that time already it's quite late. But have a look at that split reflex. Look at what happens to that retinoscope. Okay, so the reflex. It actually splits right in the center. And that is your immediate sign. And you can do that with that 5-year-old. That's the beauty of it. You might not be able to do corneal topography on a 5-year-old who is not cooperating, or on a child with Down syndrome. But just imagine with that child with Down syndrome, all you need to do is just literally just swipe your retinoscope reflex and you'll be able to find it. Okay. Now, what happens a lot of the times is I get patients referred to me by ophthalmologists who send them straight to me for contact lenses. Zara, we've tried glasses, glasses are not helping. And it is a rule for me without exception that we must try glasses with all our patients, however advanced the keratoconus is, and even if we only get the vision to 660. And that is because most patients, even if they wear contact lenses, they're going to need to take a break from their contact lenses. They cannot wear their contact lenses 24/7. So even if they are within the house and they have a pair of spectacles that gets them to 660, that will give them some form of functional vision. They may have a red eye, they may have some infections, etc. They may get an abrasion, they cannot wear their contact lens. And so it's really important to try your best to do a really good subjective refraction. And this is a stage where I say, you have to throw your standard routine out of the window. Because if you try to do your standard routine, you're not going to get the results you need with keratoconus patients. They already have very irregular corneas, and they're already very used to squeezing their eyes, to manage, and they've been doing it for many, many years. So it's really important that you put the trial frame on, do a basic, again, retinoscopy is really, really important. Because with your retinoscope reflex, you'll get an idea about where the irregularities are. You will get an idea about an axis that you can start with, put on the trial frame. Once you've got just a starting point, and the axis could be at 20 degrees, just put the lens in, and then allow the patient to turn the knob. You don't need to sit there with the cross cell. Allow the patient to turn the knob, and it's fine. You're not sitting an exam. If you did that at university, you'd probably fail your refraction exam. But remember, you're now in clinical practice. Let the patient just turn the knob, and that 20 degrees might become 60. And he says, wow, everything has really, what was skewed has now straightened out and things look a little bit clearer. That gives you that starting point. So just remember, it's really, really important to allow your patient to work with you in that subjective refraction, and you can get some amazing results. Okay, if you don't have from retinoscope, if you're fortunate enough to have a keratometer, this is how I started in my early days. I had a keratometer, and you can see, this is really easy for you to be able to see the difference on the left-hand side where you've got a regular cornea and you've got an irregular cornea on the other. This is another video, and all along, saying that I probably really didn't know what this reflex meant. So I want you just to be able to see videos so you really understand. We've covered most of it, so there we go. Have a look at this oil reflex. And when I realized what it was, after many years of practicing, I said, oh my God, that's what it is. And that's just with your ophthalmoscope. So even those of you who are not good at retinoscopy, don't have a retinoscope, just do that. And that will already be a really, really good indication that there's likely to be keratoconus there, and then of course you can investigate. These are simple things that you can do even on outreach. You can be in some really rural areas, camps, etc. And those are your two important instruments, your retinoscope and your ophthalmoscope. And many of us already have that whenever we are going out and seeing our patients. I won't go into corneal topography, but just very quickly, if you can see on the left-hand side, when I'm explaining to my patients, I always tell them about a number 8. And I said, if you look at the left-hand side, it looks very, very, symmetrical, looks like a number 8. But now have a look at this, and here where the red area is, there's very high astigmatism here, and that's very, very steep, okay? But let's just go into some that give you more indication of keratoconus. Remember the 8 we talked about? And I always describe this to my patients. Have a look at this 8. In this eye, it is bulging. And you'll normally find that it is asymmetric in majority of the patients, but you will find it eventually in both eyes. Okay, so just gives you another idea. As it progresses, it starts to look like that. So the ones earlier I showed you are quite early keratoconus. And then, of course, you start to see them, already quite late at that point. Okay. We do get some patients where you get superior corneal ectasia. And then this is what Dr. Muralidhar was talking about the two birds kissing. And this is your classic PMD as well. Okay, so let's think about contact lenses. Why are contact lenses so difficult to fit on keratoconus eyes? And it's simply because of this. If you look at that, that is your regular cornea on the left-hand side, far left. The contact lens, you know, a regular contact lens fits really nicely and wraps over the cornea. So your bog standard patient's very happy. But now look at what happens with keratoconus. You use a regular back surface and you're going to start to get edge lift there. And these are the patients where who always come and tell you, you know, I was fitted with contact lenses, but they kept dropping out. They kept falling out of my eyes. So I think I need to go for surgery. And I said, no, hold on. It's very possible that you were not fitted with the right contact lens. And they'll tell you their vision was perfect. Why was their vision perfect? Because we managed to neutralize the cornea here, right at the center, but we didn't think about the fitting, okay? As soon as you do a good fitting and you're able to wrap around that, even the very advanced keratoconus patients, the patients will have good vision and they will have a good fitting lens. What are our contact lens options generally? So in the very early cases, we can use a soft lens, and you can see here at the top, there is a soft lens. You can see the circle just around there. And then, of course, you've got your standard, which hard lenses everybody knows about. Everybody's seen this, most of them. And these are 9mm lenses, what we call corneal rigid gas permeable lenses. You have the option of also doing a piggyback. So sometimes you get a small proportion of patients who say, you know what, the fitting is brilliant, I just can't tolerate the contact lens. Should I go for a transplant? And I say, no, hold on. I've got something up my sleeve. Let's try a piggyback. So we do a soft lens, and then we put the hard lens on top. So it's a simple bandage contact lens that we would use even after cross-linking. You put a simple bandage contact lens, could be a daily soft lens, and then put your hard lens on top. And many of them will come back and say, oh, wow, actually, I feel a lot more comfortable. The modification of a piggyback is something called a hybrid lens, and that is also available. And the last one is actually the scleral lens. I really like the scleral lens, and I'm really enjoying working them even more than hybrid lenses. What happens with hybrid lenses is you've got a soft skirt in the periphery that can tear very easily. But with the scleral lens, it's a large RGP there. And we can start off with mini sclerals, which are about 14.5 millimeters. And we can go to large sclerals, which are as much as 23 millimeters large, okay? And this is the scleral lens now, okay? And you can do some amazing things with scleral lenses. I have done corneas that are even, I think, 80 diopters, 85 diopters, and I fitted them with scleral lenses. And these are patients who didn't want to get a corneal transplant. They said, I'm really afraid, I don't want to transplant. What are my options? I've had patients with Stevens-Johnson syndrome. I've had patients with corneal trauma. And we fitted some, patients that, that have really, really surprised us with scleral contact lenses. And the beauty with scleral contact lenses is it's a no-touch cornea. So remember corneas, I think I had a patient with a cornea as thin as about 150 micrometers. And I thought, oh my God, am I going to put a 9mm corneal RGP on this 150 micrometer cornea? And I thought twice, and I said, let me put a scleral lens. And the beauty about the scleral lens is it's a no-touch contact lens on the cornea. It bears, the entire bearing of the weight is on the sclera. So right here, there is no touch at all. You insert it with saline. You can even insert it with a lubricant. So you can put something like Optiv Minims when the patient is inserting, but it's this liquid reservoir that you bathe this cornea. And you can get patients who can use this with reasonably good visual outcomes for very, very many years with very little harm if fitted well to the central cornea. And it also gives you wearing time, huge amounts of wearing time, up to 16 to 18 hours a day. My youngest patient in a scleral lens is 15 years old now. And he's a monocular patient. Corneal transplant was attempted on his eye at the age of 8 years old. It rejected. They came from a very rural, very poor area. And he was, by that time, the parents were very afraid. They said, we are not going back to the clinic. They actually disappeared from follow-up for 3 years. By the time they came to us, they came back for the other eye now, saying now, because we've lost one eye, we have one eye, but the boy is complaining that he cannot see the blackboard. By that time, it was already too late for cross-linking. So I agree with Dr. Muralidhar that when you get patients where you think, one eye has an issue, has a hydrops, etc., please let's try and cross-link the other eye as quickly as possible before you lose those patients to follow up. He is the same patient who I persevered with corneal RGPs for many years. And then one day he read about scleral lenses on the internet and he came and asked me. And I said, oh my God, I was very nervous because he was only 15 years. I've never fitted a 15-year-old with a scleral lens. And we day he comes and tells me, you can see with 4.3, and you can see here where the scleral lens fits, right? Like this is a mini scleral and comes up to there. You can see here at the bottom, he inserts with saline. And this is how you bend forward and use a plunger, but you can use your fingers as they become experts. And this is how you remove the lens as well. So we did a couple of, just going to go through some studies in Africa. There are not many studies on keratoconus in Africa. This is a study that I did as part of my master's when I was doing it at Cardiff University. And I looked at the patients in our clinic. We had 254 patients. We did a 7 years retrospective study. The mean age was 21 years, but the range was 6 to 84 years. And this is when I started realizing that, hold on, what we see in Africa may be very different to what we see in the West. Because I remember when we were studying at university, we were always told that it was teenagers or post-teenagers or in the 20s that you're going to see your keratoconus patients. But we know that we are starting to see our patients much younger in Kenya. We have seen that in India, and again, Dr. Muralidhar attested to that as well. And if you look at countries in the West, New Zealand has a mean age of 17. In the Caucasians, you're looking at, within Europe and the US, Canada, you'll see an average age of what, 26 years. But we're asking our question in Africa, are we starting to see them earlier? And if we're starting to see them earlier, then is there a faster progression? Of course, more studies are required. Okay. What was really interesting for these patients is to go to all those who have optical shops and all the optometrists. Your keratoconus patients are your patients for life. They will keep coming back to you. Even if they have to see their ophthalmologist for allergy management, etc., remember that they are going to keep coming back to you. Okay, so 98% needed optical correction, a third of them needed spectacles, a third contact lenses only, and a third needed contact lenses and spectacles as well. Out of those that needed keratoplasty was 16.5%. But you have to remember that this study was done during the time when we didn't have a lot of places doing cross-linking in the country. And it was also not available on our national health system. Now, over the last couple of years, I would say last 2 years, there are a number of centers where anybody can get cross-linking done in Kenya, as well as the education has improved and it's available on national health. So we know the access has improved to cross-linking. And I believe if we had to do a study now, we might find individuals who need keratoplasties, the percentage should come down quite a bit. So the conclusion is we need, of course, we need more studies. We're asking ourselves what's happening in Kenya. But the beauty about this study also showed us that the majority of the patients in the study had moderate to advanced keratoconus. But still, after having good optical correction, that is, glasses as well as contact lenses, the binocular best corrected visual acuity was more than 6/15. So a lot of these patients can be managed after cross-linking in optical practices as long as we can do good refractions and we can do good contact lens fittings, as well as have a range at the same time. Of course, we need specialized refractive and contact lens services that we've definitely seen in many parts of our countries in Africa. It takes time. There's a lot of experience you require. You have to spend a lot of time refracting these patients before you can become confident. So definitely there's a huge need for this on our continent. I always recommend, non-surgical options to my patient, but I give them the whole lot and say, look, these are all your options. Now make your decision, especially if they've done their cross-linking. Once they feel they've done their cross-linking, I think, okay, we've done that part. Now what are the other options? What are the surgical and what are the non-surgical options for our patients? And when they're a little bit more informed, I think they can make the best choices for themselves. And we have to remember that every patient is different. Of course, definitely more research is needed. I was looking at all the keratoconus studies in Africa that I could get my hands on. And these were the 4. Of course, Kenya was the one that I had done. And these were all clinical based. And that's why I could compare all of them. These were basically retrospective studies in Sudan, Ghana, and South Africa, where they looked at their patients and they looked at their average ages and their ranges. But look at Kenya, we seem to have found the youngest, but it could also be, the setting, the hospital setting where we are based. We are based in a children's hospital. So it's very possible that we are getting younger kids coming to us. And the others range from about 12, 15 years, and of course go up to 30, 32 years. Not much of a significant difference between males and females, but Ghana found a lot more males in their study compared to females. Age versus severity. And if you look, we found two out of the 3 studies. One study they didn't look at age and severity. And 2 studies out of the 3 show that children who start younger are likely to progress faster. So that's something that we need to keep in mind. There are 2 more studies I just want to show you in Kenya that were interesting. And one was done by Dr. Mugo at the university, part of her University of Nairobi thesis. And she looked at patients who came into Kenyatta National Hospital eye clinic, and she was comparing what was the prevalence of keratoconus in these patients with allergic conjunctivitis. Her majority of the patients were between the ages of 10 and 14 years. And look at the clinical diagnosis. Look at how they picked up keratoconus. If they just went based by clinical diagnosis, they only picked up 10.6% of the patients with keratoconus. If they went with keratometry, it was only 14. But with corneal topography obviously being the most sensitive, they were able to find 30%, so a third of the patients that are coming into our eye clinics, especially children, are likely to already present with keratoconus. So it's really important that we keep that in mind. Any child that comes into the clinic that is rubbing, yes, manage the allergy, but the bell, that alarm bell of keratoconus should really ring, and we should start asking those questions. Should we refer for corneal topography at a center where it's available? If we don't have that, do we have cross-linking available in the country, etc., and what can we advise those parents? Patients with symptoms for more than 10 years had the highest proportion of keratoconus. So that's also, if we can think about how long our patients have been, when you ask them, so when did you start rubbing your eyes? How long have you had issues? You know already that, the risk factor is increasing. And of course, if you have corneal topography, this study recommended that all patients with allergic conjunctivitis should actually have corneal topography done so that we can diagnose keratoconus much earlier in this group of patients. Thank you very much. These are all the references there, and I'm happy to take any questions now.
Okay, thank you very much, Zara. This has it's an indication on and highlights how much we should focus on the way we look at allergies. We just look at allergies and we take them as something that needs to be cleared very quickly. So particularly, I think for the residents, we should take particular interest. You have seen from the studies that quite significantly, about 30% of those patients with allergies had significant findings for keratoconus. I'll just open the floor for discussion. For now, we have about 3 minutes actually before we close. We have short the time by 5 minutes. Any questions and contributions to Zara? Yeah, so we have colleagues that are listening from Tenwick in Kenya, Monze in Livingstone, and in Lusaka and Nairobi. So we have quite varied, and also Mozambique, Mundulai.
Thank you for that great presentation, Zara. Really exciting. I just have a comment. We've seen a serious mushrooming of autorefractometers across the country, and I don't know, in your case, and especially in patients who have keratoconus, would you really take results of an autorefractometer in comparison to going ahead and doing a retinoscopy on such patients?
You can use, if your retinoscopy skills are not great, then you can use the autorefractor as a starting point. But then your final will actually be that subjective refraction, where you'll put a lot of emphasis on your subjective refraction. But of course, remember when you have young children, and if you're dealing with a 5-year-old and you can't do an autorefractor, or you can't rely on that autorefractor, and in special populations like children with Down syndrome, then you might be disadvantaged just having the autorefractor.
Okay, Zara, there's a question from Saya. She's asking, is there a benchmark in visual acuity in distinguishing ghost images in suspecting keratoconus?
Usually the vision will be a little bit less than 612. You'll tend to find that they don't notice the ghosting as much when the vision is better than 612, but anything less than 612, 618, they might start, but it will all depend on how the cornea is thinning, where exactly it's thinning on the cornea, because remember the cornea is our window. That's what we see through, right? And depending on which part is irregular and which eye and how advanced and how different, because remember the dominant eye could take over as well. So it's very difficult to just a visual acuity to it. But generally, if we were saying, if we just took monocularity, is anything less than 612, you might start to get some ghosting.
Okay. I see no questions. I'd like to hand over to Dr. Kasongole to conclude for us.
Thank you, Dr. Mumbi. It's been a great session, and also special thanks goes to the faculty, Dr. MDR and Zara, and Dr. MDR especially for having taken time. I know in India it's now past 9 p.m. We are so humbled to have had you on this evening, and also this is our first international webinar as ZOS, and would like to see this moving forward, have more sessions, and I think the attendance has been superb. We've had attendance coming all the way from South Africa, Mozambique, Kenya, and Ghana. So thank you everyone for having joined us. Not to say much, I think we can call it a day, and hope to see everyone soon. Dr. MDR, greetings to everyone in India.
Thank you so much, and I certainly can't wait. Dr. Jara, excellent presentation. Thank you so much. You covered every aspect. Thank you so much for that. And Dr. Mumbai and Dr. David, yeah, it's my privilege. I'm really honored to be part of your endeavor to take academics to the next level. We'll collaborate and always there for you. Okay, you can count on me. Thank you once again for your generosity. Okay, thank you. Bye-bye.
Thank you.
Thank you so
Good
much.
evening to you.
Bye.
And Shani. So what do you say for good boy? Shalapo. Yeah, Shalapo.
Okay.
Thank you. Bye-bye. Right.
Okay, bye.
Bye-bye. Good night.
Thank you,
Bye.
everybody. Bye.